We looked at the HIV life cycle and the mechanism of action of antiretroviral agents. We looked at the DHH guideline recommendations for treatment-naive HIV patients. Now, given a newly diagnosed HIV patient, ensure adherence to ART is optimized. Let's take a look at some causes of treatment failure. It all starts with insufficient drug level. When there is insufficient drug level, HIV starts to replicate in the presence of drug, and that can lead to selective pressure. And selective pressure will basically select for strains of HIV that are resistant to the drugs, to the antiretroviral drugs. Of course, there's always the possibility that these resistant viruses could have actually been transmitted to the patient from someone else. So if someone else has resistant virus and, whether sexually or, by other means of transmission, that resistant virus can also be in the patient. And resistant virus, of course, will lead to treatment failure. There's not much we can do to prevent the transmission of resistant virus from someone else. But we can do a lot of things to prevent insufficient drug level that will lead to resistant virus. As pharmacists, we should always check for drug interactions. So drug interactions, depending on the interaction, of course, can result to insufficient drug levels. Some drugs may be rapidly cleared, so it's important to make sure that the dose is adjusted when necessary. Poor absorption, so depending on the drug, whether it needs to be taken with food, the absorption of the drug could be affected, so that's important to keep in mind. And of course, there are some things that are out of your control, like host genetics. And sometimes the wrong dose may be given to the patient. So as pharmacists, we can ensure that the right dose is given. And historically, suboptimal potency of drugs was leading to some of this resistant virus. Nowadays, the drugs are very potent, so we don't really have that issue anymore. And of course, the biggest thing that results in insufficient drug level that we can intervene with are poor adherence. So poor adherence could be due to different causes. So one is social or personal issues. There is a lot of stigma with HIV. So, if someone is hiding the fact that they have HIV, this could actually prevent them from filling their prescription or actually taking their drugs in front of other people, such as friends and family. There could also be issues with a regimen. So, for example, if there is a pill burden, if the patient has to take multiple pills throughout the day, or if there are strict requirements for administering the drug. So for example, if somebody has to take it on empty stomach and they're eating all the time, that could be an issue. Or vice versa, if something, if a regimen needs to be taken with food, but someone is doing intermittent fasting, for example, that can cause a problem. And of course, toxicity. So sometimes, although most regimens nowadays are well tolerated, occasionally if somebody has some toxicities or some adverse effects of the drug, that they could actually stop taking it. For example, if somebody starts to have a rash or nausea, that could be a reason for people to stop taking their drugs. And adherence is extremely important. Now, this study was was published in 2000, so these numbers may actually be different today because our drugs are more potent. But what they looked at is that they looked at different percentage of adherence and looked at the percentage of patients that actually had virologic failure on the vertical axis. So you can see that when adherence was less than 70%, the HIV regimen basically became worthless because the failure became as high as 82% or even more. And you can see that around 90 to 94% adherence was really required to have high or less failure rate, and really 95%. And of course, those agents that were used here were less potent compared to what we have today. But regardless, it's recommended that adherence of 90 to 100% is necessary to achieve and maintain viral suppression. So it's very important to talk to patients to make sure that they're actually ready to adhere to these drugs, because this is a lifetime commitment. So we need to make sure they're ready for adherence before we actually initiate them, because once you initiate them, you do not want them to interrupt the regimen, because that will lead to selective pressure, which can lead to resistant viruses. So this 90 to 100% adherence is very crucial. And if you think about it, if somebody misses one pill a week, that's about 85 to 86% adherence. So even missing one pill a week is not enough. So they need to, they should not miss more than 2 pills a month. So 2 pills out of 28 days will result about 93% adherence. Now, how do you measure adherence? There's no gold standard for measuring adherence, but there are things that we can do. So if you actually get the viral load in the patient and it's suppressed or is undetected, that's a very good indicator that the patient is actually taking it, so it's working. Studies have shown that patients self-report usually overestimates. However, if the patient actually reports that they're not adherent, that's a very good indicator of suboptimal therapeutic response. And one thing that we can do as pharmacists is to actually check pharmacy records. For example, if somebody had a 30-day supply and they haven't filled it for 3 months, that's a good indicator that they haven't been taking their medications. And you can actually occasionally do a pill count to make sure that they're actually taking it. Now, some factors that are associated with reduced adherence is, one is pill burden. So in general, if you can give the patients a single pill, that would improve adherence as opposed to multiple pills. One issue is low literacy. So if the patient cannot read the instructions that are on the label, that could lead to adherence. So for example, if you have a regimen that the patient needs to take twice a day, but they're taking it once a day, that's going to result in suboptimal exposure to the drug. So it's important to make sure that the patient understands how to take their medications. Younger age is associated with adherence failure, and usually because younger people are just not used to taking medication, so they may not know how to, or they may not remember to take it, whereas older people who already take drugs for hypertension, for example, they're more used to it, so they have the habit of going to their taking their medications daily. Some other challenges, especially in older patients, are polypharmacy. So if somebody has to go through 10 bottles, that's cumbersome. Some elderly have vision loss, so they may not be able to read the label even if they have the literacy, or they may not see where their medication is. And of course, as we all age, we'll have cognitive impairment, so they may be confused, they may not remember if they took it or not. They might think that they already took it, but they didn't, so that can lead to adherence issues. Other things include stigma. So some people may not want to have their friends know that they're taking this medication, so they may want to hide it. They may not have the opportunity to take it. Other psychosocial stresses, especially active drug use or alcoholism, can reduce adherence. So, if somebody's under the influence, they may not necessarily be, oh my God, it's time for me to take my pills. They may be doing other things and not be aware of it. Mental illness, of course, can lead to reduced adherence, and of course, medication adverse effects. So if somebody's experiencing this, they're less likely to want to continue to take it, especially if this is a lifetime commitment, which can result in treatment fatigue, because they have to keep taking this pill every day for the rest of their life. And occasionally, cost and access to the medication can be an issue. And of course, the opposite of those factors will improve adherence. So for example, if you simplify the regimen, once daily dosing, that can improve adherence. And when it comes to adherence, we as pharmacists have a key role. There are many things we can do to improve adherence at the pharmacy. Perhaps the most important intervention we can make is education, whether we provide education to other clinicians or education to the patient regarding the actual HIV infection, how to treat it, how to prevent it, how to prevent transmission, how to stay adherent to the regimen, how to follow up with their clinician and individualize the regimen to the patients. And there are tools that we have at our disposal, such as pill boxes. Pill boxes are useful when someone has multiple pills to take, so they can, especially if the schedule is different. So if one pill is twice a day, another pill is once a day, you can easily set those up in a pill box. Whereas pill box might not be as useful if just a single drug once a day. You know, if in fact pill boxes are large and they take space as compared to a single bottle. But if somebody has multiple bottles of pills, a pill box will be very valuable. There are dosing packets that we can use to make it easier for patients. And of course, because oftentimes patients forget to take their drugs, there are tools we can use to remind them. So there are telephone services that they can subscribe to. They can receive messages. And of course, with current technology, there are smart devices that you can use apps on. So including smartphones and other devices. You can also, if someone doesn't have a smart device, they can actually set an alarm on their watch. So when the alarm goes off, similar to some of the techniques that we tell patients to remember their birth control, basically. And of course, there are other tools that we can do to improve adherence. Now the question is, so if someone has adherence issues, we still need to treat them. So how are we gonna approach it? So because adherence, as I explained, is going to lead to suboptimal exposure to the drug, and then selective pressure will lead to drug resistance, one thing we can do in patients who have adherence concerns is to actually use drugs that have a high genetic barrier to resistance. So we can use either dolutegravir or darunavir. So these darunavir is a protease inhibitor, and dolutegravir is a second generation integrase inhibitor. And these, because they have a high genetic barrier, are recommended in these patients, because if they miss a dose or two, these drugs are less likely to lead to resistance compared to other regimens. Now, it's not to say that these are 100% proof. It's just that these are less likely to select for resistance. And bictegravir is not in the guideline for this purpose. Bictegravir is also a second generation integrase inhibitor with a high genetic barrier. So as more information becomes available about bictegravir, that will potentially be an option as well. But as of right now, it's not in the guideline for this purpose specifically.